For our keynote address, we have the absolute honor of hosting Laura Trolio, Acting Deputy Commissioner for the Office of Public Health, working under the Commissioner of Health for New York State. Laura Trolio oversees a comprehensive portfolio addressing chronic diseases, infectious diseases, injuries, environmental health, maternal and child health, among other critical public health issues. For over 20 years, Laura has been at the forefront of public health and work to advance health equity, working within community-based organizations and working at governmental public health offices. Her expertise spans program design, implementation, management, evaluation, quality improvement, policy formulation, and strategic planning. Her work has made significant impacts on HIV/AIDS, sexual health, drug user health, hepatitis, LGBTQ health, and public health workforce development. I have had the honor of seeing this firsthand. Laura's passion for public health, commitment to health equity, and effective public health practice sets her as a beacon that guides efforts to address health disparities and promote health for all of New Yorkers. Laura, thank you so much for joining us today. Thank you for driving here from Albany. Thank you for taking time out of Mother's Day to get here. And I really look forward to how you're going to inspire us for our next steps.
Good morning, everybody. Let me get myself situated here. All right. So the theme of today's conference is Nothing About Us Without Us. Advancing Health Equity Through Community Engagement is both a statement of values and a call to action. It challenges us to think differently about how we define expertise, how we design solutions, and how we measure success. At the New York State Department of Health, this principle is central to how we approach our work because we know that improving outcomes requires more than programs and policies. It requires partnership. And if you haven't already sensed a theme, my few words today will probably start to connect our previous comments that have already been said. This partnership requires trust, and it requires a commitment to ensuring that voices of our communities are not just included, but are also shaping the decisions that impact their health and well-being. At its core, it reminds us that improving health is not something we do alone. It's something that we do for our communities. It's something that we do with them. And actually, I'm pretty verbose, Jen, so how do I scroll down of the room? There we go. At its core, it reminds us that improving health is not something that we do alone. It's something that we do for our communities. And when we get that right, when we center community voice, and when we build trust and work collaboratively, we create solutions that are more effective, more equitable, and more sustainable. So, why the theme of today matters. This theme carries profound implications on how we approach public health, research, and community engagement, and it also pushes us to reflect on a few important questions. Who's at the table when decisions are made? Whose voices are shaping those solutions? And just as importantly, who is missing at the table? As we think about advancing health equity, these are not abstract questions. They're central to whether our work truly meets the needs of the communities that we serve. At the New York State Department of Health, health equity is not a single program or initiative. It's a commitment embedded across how we operate as a department. It means working alongside our communities, partnering with community-based organizations, and using data not just to measure disparities, but to act on them. It also means recognizing that improving health outcomes requires more than programs and policies. Did I just say that? It's a partnership. So this is a slide that talks about our mission, vision, and values. One of the first actions that Commissioner McDonald did when he started in his role several years ago was to ensure that we took time as a department to establish clear definitions for health and health equity that were a shared understanding across the department. So a mission, vision, and values was established. That foundation is critical because if we're not aligned internally within the department, and we don't have the defined definitions of what health is and what health equity means to us, it's difficult to operationalize this in practice. So this work is grounded in a commitment to improving health outcomes for all New Yorkers while addressing the inequities that historically have shaped access and opportunity. So I'm just going to go through what the New York State Department of Health's definitions are so that you can have an understanding of where our viewpoint is coming from. So the definition of health, as through New York State Health Law, Article 2F, says that health is a state of optimal physical, mental, and social well-being. So what is health equity? Again, New York State Public Health Law, Article 2F, says that health equity shall mean the highest level of health for all people and shall entail focused efforts to address avoidable inequalities by equalizing those conditions for health and for those that have experienced injustices, social economic disadvantages, and system disadvantages. So when we break this down, as I said before, this definition is intentional. Not everyone has the same starting point or the same advantages, yet everyone deserves a fair and just opportunity for the best health outcomes. When defining health equity, it means everyone has a fair and just opportunity to be healthy. This means that everyone must be able to access and experience the conditions that contribute to optimal health. Examples: safe and secure housing, social support networks, nutritious food, clean air and water, freedom of discrimination based on race, gender, sexual orientation, disability status, and any other part of one's identity. In a world where health equity is the norm, or ideal, everyone has fair and just access to these conditions and therefore has a fair and just opportunity to achieve optimal health. This status of health inequalities is not accidental. Social determinants of health have historically been shaped by systematic discrimination based on racism, and we should shift towards a health equity foundation to help mitigate some of the historical discrimination and uplift those around us in the public health sector. When thinking about health disparities, it's about outcomes. Health disparities refer to measurable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health between population groups. Social determinants of health, by definition of public health law, shall mean life-enhancing resources such as ability to, what I had mentioned before, foods, healthy foods, quality housing, economic opportunity, are made available to populations that effectively determines the length and quality of life. Social determinants of health are wide and complex, as you can see on this page. In communities, social determinants of health may be transportation access, healthcare workforce shortages, food access, housing quality, and even broadband digital access in today's times. So one of the things that we did several years ago at the New York State Department of Health is we built a definition to continue our foundation of health equity that understands what health equity is. This depiction comes from the Robert Wood Johnson Foundation, and it's just an easy visualization that we use to distinguish the difference between equality and equity. So as I was saying before, one of the first things one of the most recent things that we did at the New York State Department of Health was develop an Office of Health Equity and Human Rights, which now plays a central role in how we do our work at the department. The Office of Health Equity and Human Rights, or we call OHAIR, is the very existence that reflects the vision, framework, and strategy to achieve diverse, equitable, and inclusive programming at the department. The office, it makes up the AIDS Institute, the Offices for Minority Health and Health Disparities, Prevention and Diversity, Equity and Inclusion, and O'Hare's portfolio is very broad. It includes the prevention and treatment of communicable diseases such as HIV and sexually transmitted infections, LGBTQ plus health and wellness, drug user health, harm reduction, and health disparities prevention. So this slide really just gives a background of the short tenure of the Office of Health, Equity, and Human Rights. It was established in August of 2022. In July of 23, health equity statements were developed, which included civil service and New York State job postings were included in the interview evaluations forms. That was one of the very first activities, is ensuring that we're recruiting employees at the department that understand what health equity is, and that we're assessing their understanding as they are as they're being recruited and onboarded into the department. In May of 24, the mission, vision, and values, which I showed previously, included a statement on health equity, and then in August of 2024, we launched our very first iteration of the health equity plan, which guides all of the work at the department. The office also has its own motto and core values. As you can see here, the 4 values are to champion equity and justice, cultivate mutual respect, elevate voices and communities, and foster meaningful, intentional inclusion. And optimal health factors is also the building a foundation of health equity. And as you can see here, and I spoke to before, here are some examples of that. Just calling out quality healthcare services, which was discussed a little bit earlier this morning, green spaces, quality education is a social determinant, and living wages and secure jobs, just as examples. So some of the health equity values: health is a human right and should not be determined by discriminatory social structural factors. Achieving good health means a complete state of well-being, not just the absence of disease. There are systematic factors that impact individual behaviors and one's ability to secure basic life necessities. And when advancing health equity in our work, we commit to centering race explicitly, not exclusively. So since we're in Ithaca, we figured that we would take a little approach by zooming in on rural health in New York State. And this approach operationalized the health equity the department is currently focusing on due to some funding resources that we've recently received. So when we apply a rural lens, we see how these determinants can show up uniquely across communities. Rural communities often face challenges such as geographic isolation, fewer providers, limited infrastructure, but they also bring strengths. Social networks are strong, trust is deep, and there's local leadership that really engages. These strengths are essential to building solutions that are both effective and sustainable. When we look at health equity through a rural lens, we see a set of challenges that are both distinct and deeply interconnected. These barriers are not isolated, they build on one another and shape how individuals experience and access care. Access to care is influenced not just by insurance coverage, but by whether providers are available, whether transportation is reliable, whether services are within a reasonable distance, and whether there's workforce that's available to take care of the needs. Transportation and distance can make up even routine care very difficult to access, especially for individuals who may not have consistent access to a vehicle. And beyond healthcare, we see impact of broader social determinants of health, such as access to affordable and nutritious and stable food, housing, and reliable broadband, as I mentioned before. These are not just logistical challenges, they're equity challenges because they directly influence who is able to access care and achieve optimal health. We are working to strengthen the public health and healthcare workforce to support local systems by recognizing that there are many rural communities, local health departments, and small systems that are the backbone of our care. We're also focused on expanding access through partnerships, bringing together healthcare providers, community-based organizations, and partners to improve the coordination and research to address these concerns. And importantly, understanding that improving outcomes requires us to look beyond clinical care and address the conditions that shape health in the first place. So you might have heard of the Rural Health Transformation Grant that the federal government has awarded to all of the states across the country. We were an awardee of this funding, and this project is supported by the Centers for Medicare and Medicaid Services, or what we call CMS, of the New York State Department of Health and Human Services, or HHS, as part of a financial assistance award that totals $212 million in a budget period with 100% of it funded by CMS HHS. And the contents of these, the next couple of slides are some of the information that we have decided to how we would like to use the funding for this grant. So the goals and strategies. One is rural community health integration. We want to establish rural health partnerships that facilitate comprehensive care coordination, build and grow integrated health networks to enhance healthcare delivery and outcomes in rural areas. Strengthening rural communities and technology-enhanced primary care. Expand the number of patient-centered medical homes that are recognized providers and accelerate their adoption of enabled technology. Third, rural roots, building sustainable rural healthcare workforce. Comprehensive strategies to recruit and train more practitioners for rural communities by combining planning, targeted education, and innovative support that addresses both immediate staffing needs and long-term capacity building. And fourthly, investments in technology innovation and cybersecurity enhancements, which strengthen cybersecurity for rural facilities and expand access to care through telehealth and strategic efforts to partner with healthcare facilities and practices. So that is just a quick snapshot. This program is just beginning. These are really just ideas that are starting to develop, and as I'm hoping as we continue our conversation today, I can be able to bring back or encourage you to reach out to the department so that if you have innovative ideas with this funding that was recently received, we'd love to be able to partner with you. So as we move into operationalizing health equity at the New York State Department of Health, health equity, as I said, is not just a concept. This work is guided by our health equity plan. And as I mentioned before, we launched a health equity plan in 2024, which is embedded across programs, policies, and partnerships across the department. But operationalizing health equity requires more than intention, it requires action. So I want to highlight a few key ways that we're doing this in practice. One, through cross-sector collaboration, community engagement, workforce development, data-driven decision-making, and strengthening partnerships. Operationalizing equity means turning these principles into action. Key factors to this includes data to inform decisions, working across sectors, investing in the workforce, working with communities, and continuing to strengthen partnerships, all while ensuring that we're embedding equity into programs and policies. One of the most important ways that we operationalize equity through cross-sector collaboration. Many of the challenges that we are working toward address not only a single system. It impacts health, safety, well-being, and require coordinated responses. An example of this is at the department, working to support the implementation of Public Health Law 2805-Z, which focuses on strengthening how hospitals respond to domestic violence. This includes requiring hospitals to establish policies and procedures, provide ongoing staff training, and designate coordinators and building connections within community-based domestic violence programs and providers. To support this, a cross-cutting strike team was developed internally at the department to bring together expertise from within the department and partners such as the Office of Prevention and Domestic Violence. This collaboration is helping develop not only regulations, but also tools and guidance needed to support this effort and implementation. Just an example of how advocating for health equity requires us to work across sectors, aligning expertise, resources, and systems to address complex challenges in a coordinated way. So community engagement is central to how we operationalize equity as well. At its core, this means recognizing that communities are not recipients of solutions, but they're partners in shaping them. Across the department, we're working to ensure that community voice is incorporated into program design and implementation. This includes investing in community-based organizations and creating opportunities for communities to inform priorities, strategies, and solutions. Another critical component is operationalizing equity in workforce development. A strong, well-trained workforce is essential to ensuring that communities have access to the services and support that they need. So as Jen said, an example of this is the New York State Public Health Core Fellowship Program. This program was launched to build public health capacity across the state during the COVID response period, while also strengthening long-term preparedness for future public health challenges. Throughout this program, fellows were placed in communities across New York State, supporting local health departments and community-based organizations. And a key component of this program has been partnership, including Cornell University, which played an essential role in developing and delivering the public health essentials training that all fellows were required to complete while in their fellowship. Moving on to data. Data is another critical tool to address disparities, and we must first be able to identify and measure them. So we use data such as the New York State Health Equity Reports to better understand health outcomes to both the state and local level. But data is not enough. It must be translated into action, informing programs, guiding investments, and shaping policy decisions. When used effectively, data allows us to be more intentional and more targeted and more impactful in our efforts to advance health equity. Strengthening partnerships is another essential part of operationalizing health equity, as we had strongly mentioned. We work closely with local health departments, maintaining consistent communication and support. These relationships are critical, and particularly in rural communities where local health departments play a central role in delivering services and responding to community needs. We continue to collaborate with also academic institutions, including Cornell, to support research, training, and workforce development. So bringing it all together, after discussing how we operationalize equity across the department, it's important to highlight how this work comes together in a coordinated way. And through that, the framework we use is called the Prevention Agenda, which is our state health improvement plan. The Prevention Agenda brings together many of the concepts that I discussed today. It emphasizes prevention, focuses on reducing health disparities, and addresses the broader social determinants of health that shape our outcomes. Just importantly, it aligns partners across sectors, creating shared framework for action across state agencies, local health departments, healthcare providers, community-based organizations, and academic institutions. The current Prevention Agenda takes a broad and comprehensive approach. It's organized around 5 key domains aligned with social determinants of health, including economic stability, education, healthcare access, neighborhood conditions, and social and community context. Within these 5 domains, There are 24 priority areas that address health conditions, behaviors, and systematic factors that influence these health outcomes. And what makes the prevention agenda powerful is not just what it prioritizes, but how it's implemented. It's built through collaboration, informed by data, and grounded in community engagement. And this serves as our roadmap. This slide shows the new prevention agenda framework that is through the 2025-2030 cycle. It has health equity, which focuses on addressing the social determinants of health and reducing health disparities across populations. Prevention across the lifespan to emphasize the importance of investing in primary and secondary prevention, health across all policies. Oops, sorry. I'm losing my... There we go. Yes, thank you. Yes, thank you. So the prevention agenda reflects a simple but critical idea. Improving health in New York State cannot happen for communities, but with communities. It embodies the principle of nothing about us without us by ensuring that community input, cross-sector collaboration, and shared responsibility are built into how we approach this work. It also reinforces that advancing health equity is not the responsibility of any one organization or sector. It requires collective action, and it provides a structure that allows all of us across disciplines and roles to contribute to a shared vision for improving health outcomes across the state. I want to come back to today's theme. Again, at its core, it reminds us that improving health is not just something we do alone, it's something we do for our communities. It's something we do with our communities. And when we get that right, when we center community voice, build trust, and work collaboratively, we create solutions that are more effective, more equitable, and more sustainable. The work happening across the Department of Health, from the prevention agenda to community investment strategies to cross-sector initiatives, it all creates a foundation. But its success depends on partners like you. Researchers, students, practitioners, community leaders. The future of this work will not be defined by plans alone, but by how we bring them to life together. So I encourage you to ask yourselves, how can we use our influence to go beyond the words of our commitment to action? The work happening across the New York State Department of Health, hold on. As you move through today's sessions and conversations, I encourage you to think about what role you can play in advancing this work. Because advancing health equity is not just about understanding the challenges, it's about acting on them. It means centering community voice in the work that you do, building partnerships that are not transactional but authentic and sustained. It means taking what you learned through today's conversations, presentations, and connections and asking how it can be applied to your own work in your own communities. So as I close, I want to return to the, why do I feel like my slides are out of order? So this is, I think what I want to say is thank you for having me. Thank you for allowing me to be part of your day. And thank you for all of your work and commitment in advancing health equity across New York State and might I even say as a global influence in the work that we do. We need, we're all in the same room together today because we all believe in the same thing. We all believe in the importance of our work. And I just empower you in the leadership roles that you all hold, in the positions that you hold, in the communities that you live in, to keep this at the forefront of what you do and how you move through your life. And together we can make a difference. So thank you so much.